Hello, everybody.
Hello. Hi, Marsha.
So, hello, Winnie. How many of you have experienced neck or back pain in the past? I figured it would be the majority of the room. I'm going to talk to you today about one particular type of spine treatment that I have my certification in, and several of the other therapists here have learned a lot from me in terms of how to treat people with this approach, and so our clinic as a whole does a pretty good job of utilizing this as one of our tools. Next to the common cold, low back pain is the most common reason that individuals visit their doctor's office, and I think you guys represented that pretty well since just about everyone raised your hand. Billions of dollars in medical expenses are spent on this condition. And McKenzie is a method that provides a benefit to both you and your practitioner. It helps to eliminate the need for some expensive and invasive procedures that might have to take place. It's a problem-solving approach that we use clinically to determine what movements and directions and postures create your pain and which take them away. So I'm going to talk to you a little bit more about kind of the whole assessment procedure and how it is used in terms of treatment and how you can apply it to your life moving forward. The McKenzie method was developed in the 1960s by a physical therapist in New Zealand named Robin McKenzie. There are about 2,900 MDT therapists in the US and only 19 in New Hampshire at this point. McKenzie stumbled upon his theory quite by accident. He had a patient one day who was complaining of low back pain with symptoms going down his leg, and he had his assistant bring Mr. Jones into the treatment room and told the assistant to have Mr. Jones lie on the table. The table had been propped up at one end from the previous patient, and the assistant did not realize this is not how Mr. McKenzie wanted it to be. The patient laid on the table on their stomach, so they were way propped up in this backwards direction because that's what they were told to do, was lie on the table on their stomach. So when Mr. McKenzie came into the room and found the patient lying in that position, he was actually quite startled and was afraid that he may have done something to harm the patient inadvertently. He asked the patient how he was, and the patient said, "This is the first time I've had no pain in my leg or my back in over 3 months." Robin McKenzie thought, that's interesting, because at that point in time, the general theory was that we should not do extension of our spine to an extreme motion because that could be harmful. But he started to think maybe that wasn't so harmful if this person is first time pain-free in 3 months, so I'm going to explore this a little bit further. That was the end of the treatment session for the day. The patient felt better. He got sent home. He came back a few days later and reported that he continued to lie on his stomach and he continued to have no pain. They proceeded through a little bit more problem-solving procedure to make sure he had that full range of motion, and the patient later reported, several months down the road at the grocery store or whatever it may be, that he never had a return in his symptoms, and it was that simple to solve it. Now, it's not that simple for everybody, but it's part of what set him down his path to kind of do some problem-solving and figure out why did this work for this person. Most spinal pain is believed to be mechanical in nature, and most responders will show patterns of response to pain and function based on a certain direction of movement, and that allows us to classify them a certain way. We're going to talk about that in a little bit. Pain of mechanical origin occurs when the joint between two bones has been placed in a position that overstretches the surrounding ligaments or other soft tissues. So some people who have heard about McKenzie and the McKenzie method have an untrue belief that it's only for treating disc problems, and that's not the case. It's for treating any kind of mechanical pain in the back that often sends symptoms radiating into the leg. So I'm going to do a little demonstration with you guys. I want you all to put your hand palm up, and I want you to bend your index finger back until you just start to feel some strain. Okay? That's the point where there's some strain on the tissue, but there's no damage being done. And if you continue to bend your finger back, you're going to hit the point where you get to pain and you think, I'm not so keen on this, I don't really want to do it anymore. And if you were, I don't know, masochistic enough and kept bending it backwards, you would create damage. Okay? So this gives a little demonstration about kind of the way mechanical pain develops. Initially, we have a situation where there's strain. We may move in and out of a position with our back or our neck where we feel some strain but we move out of that position and the pain goes away. If we keep moving into that, so we're maybe hauling wood all day long, it becomes less than strain, it becomes pain, because we've repeated that over and over and pushed it a little bit further. And the potential for damage then is increased, because the more we push that limit, the more chance we have to overstretch some of the structures, the soft tissues. Once soft tissues are damaged, the pain will be felt until the healing is complete and the function is fully restored. So a good way to kind of picture this is if you have a cut on the top of your knuckle, when you first cut your finger, every time you bend your finger until the scab develops, you have the potential for kind of reopening that cut or recreating the damage. Once you leave it bandaged long enough and leave it alone for a few minutes so that the scab can develop, you create a situation where you then can bend your finger and you still have a scab there, but you have freedom of motion without that scab coming open again. Well, of course, in the spine, it takes a little bit longer than a few minutes, like the finger analogy, but that gives you a sense for why we're going to talk about avoiding certain directions of movement when we get into some of the techniques that we use. Once the healing has completed, it is important to move into the direction that you were previously avoiding to ensure that you regain your full range of motion, and we'll talk about that as well. When tissues heal, they tend to form scar tissue, and this tissue is less elastic than normal tissues. It tends to shorten over time and give a sense of stiffness, which can also be part of what creates pain. And as I said, appropriate exercises need to be performed to restore that normal tissue mobility. One of the central tenets of the McKenzie method is that self-healing and self-treatment are important for the patient's pain relief and rehab. In a truly, purely McKenzie clinic, we would not use modalities like heat, ultrasound, cold, hands-on stuff, massage, none of that. He truly believed that it was based on patient movement, patient education, and patient carrying out what had to happen to make them better. At Cioffredi Associates, we tend to use a little bit more of an eclectic approach, so we certainly want to teach you what to do, how to do it, when to do it, but we tend to use other things to help the process along, some, things like massage and heat and ultrasound and the dry needling and all the other things we do. We tend to picture the McKenzie as a little bit more of one piece of our toolbox and use as many tools as we need to get you better as fast as we can. The McKenzie approach can help to centralize a patient's pain. So in the example I gave you of Mr. Jones and Robin McKenzie, it brought the pain out of his leg into his back. And that allows us then to treat the source of the pain rather than the symptoms. So lots of times a patient coming in complaining of leg pain will often, think it's a little bit funny that their doctor has sent them for therapy on their back because they don't have an understanding that the leg pain is actually coming from their back or their arm pain is coming from their neck. And what the McKenzie method does is works on centralizing it to the place it came from and then taking it away. So this is an example of centralization of lower extremity pain. So it may start in the foot, and as we're working on treatment, the patient might start to tell me, I never have symptoms below my knee anymore, but it's really getting quite intense in my back. And I never want to say that's good because I don't want someone to have more pain anywhere, but actually it's good because we're bringing it up to the center where it started from, and the last place we take it away from is the spine. And then this is a similar diagram of what it looks like when we're centralizing arm pain. Interestingly, I've also seen diagrams related to the McKenzie treatment that talk about head pain. So headaches can also be referred from the spine, and some of the McKenzie treatment can treat that as well. Once the directional preference is found, the McKenzie exercise treatment begins with exercises that are directly related to what we discovered inside the treatment. So the goal is to centralize that pain and to teach you how to do it. So in 2004, there was a review of 14 studies that had been published over that series of years, and the prevalence of at least partial centralization of symptoms through this directional movement approach, which is what the MDT or McKenzie approach is, was 70% in 731 subacute back pain patients and 52% in the chronic back pain patients. Now, in terms of medical treatment and physical therapy treatment, those are actually pretty good statistics for decreasing someone's pain. In another study, 11 patients with confirmed MRI disc prolapses or herniations, over half of those people also had weakness or sensory loss in their leg, were treated with repeated end range movement, which is what McKenzie uses, reevaluated after 5 treatment sessions, and centralization of that pain had occurred in 8 of 11 patients. The interesting thing is that there was no change on their MRI. So if we looked at the disc bulge on the MRI, and took note of the patient's symptoms, we performed the treatment, the symptoms reduced, but the MRI didn't change. And so that's a good piece of information for patients to have. The imaging, the x-ray, the MRI doesn't always tell the whole picture. We might see something that looks nasty on the MRI and patients lose hope and think, oh, I'm never going to be out of pain. But there's lots of things that can be done to decrease pain, even though the imaging may not change. And so just because there's a positive finding on an image doesn't mean it has to be the source of your pain, and vice versa. We can have people with pain that has imaging that shows nothing. So it's only part of the picture. So the assessment procedure uses a systematic progression of applied mechanical forces and monitors the patient's response to those forces. This allows us to classify the patient into one of these types of subgroups that I'm going to go through here next. So he came up with 3 classifications. One is the postural syndrome. In the postural syndrome, the patient has full range of motion. They have pain when they're in a particular position. So let's say I have a patient who comes in and says, every time I'm sitting, I have back pain, okay? And they're sitting in a slumped posture. But as soon as we pull them out of that posture, they say, well, I don't have any pain as long as I sit up straight. What we need to work on in that situation is more patient education and strengthening, getting their muscles to be able to support them in a proper posture. There really isn't any structural problem going on. It's just that they're resting at that point of strain, which causes discomfort over time. The next classification is the dysfunction. There's shortened structure, shortened tissues. So the patient may come in and I'll have them bend backwards and they say, I have pain right when I get to there, and I know that their full range would be here. So they have pain before what would be considered normal range because they're bumping into tightness or restriction in a tissue. And so we need to work on improving that mobility and then moving into the strengthening and control and making sure we get them learning how to control their body in the new range of motion that we help them develop. And the last classification is derangement. In derangement, there's an anatomical disruption. So this might be a disc herniation or bulge, it might be a ligament tear or something like that. And so what we need to do in this situation is figure out how to keep the patient out of whatever movement or position they perform that creates pain, teach them how to work on staying out of that movement or position to allow the healing to happen. If we go back to the analogy about the cut finger, if we stay out of the trouble range of motion long enough, we can produce an environment that allows healing, and then we can move the patient back into the range of motion that once caused pain without them having their symptoms. All 3 of those syndromes that I just talked about occur in the neck, the mid-back or the thoracic region, and the lumbar region. And when we get into talking about derangements, there tend to be 2 categories that McKenzie uses. There's reducible derangements and irreducible derangements. In a reducible derangement, we're able to produce a change in the clinic. We're able to perform a movement. We're able to have the patient say, you know, it's not in my foot anymore, it's only at my knee. It's not in my knee anymore, it's only in my buttocks. And clearly it's not, I'm not sure, maybe it's a little better. This is definitely making a difference. We're able to centralize it, and we're able to maintain the centralization. The patient is able to come back in and say, you know, I haven't had it to my foot since I left here. I do still sometimes get it in my thigh, and we need to keep pressing on at that point. But we're able to centralize it and keep it there. There's patients who are irreducible. Their symptoms are so intense, or the pressure on the nerve or whatever structure it is that's causing their pain is so severe that we can't reduce it, we can't centralize it, or if we centralize it, we can't keep it there. So we might centralize it while they're laying on the table performing a certain exercise. As soon as they get up, the symptoms are right back. Repeat the exercise. As soon as they get up, the symptoms are right back. And it doesn't matter how much problem solving we do, but we can't get it to stay reduced. Typically, he says 3 to 5 sessions of problem solving is the maximum that he would allow in order to kind of label someone irreducible. And those may be the patients who eventually become surgical candidates or need other types of therapy to help their situation. He talks about some severity indicators. Generally, if a patient comes in and has central or symmetrical type symptoms, they're easy to centralize and easy to maintain the centralization. If they have unilateral symptoms that only go down to the knee, that's also pretty easy to solve. Usually when those patients come in, I think 2 or 3 visits and we're going to have this pain significantly reduced. When the symptoms go all the way down to the foot, doesn't mean we can't centralize it, just takes longer, a little bit more effort, a little bit slower process because the damage to whatever tissue is causing the problem has been more significant. So it takes more time to heal that tissue. So when we take you through a McKenzie evaluation, we're trying to determine your directional preference or the principle of management that we're going to use. Part of that comes from just an interview with you. You're going to come in and tell me something like, every time I sit, my back is killing me. Every time I stand up or walk, it feels so much better. I'd take that bit of information and think about what does that mean for your spine. When you're sitting, your spine is in flexion, so it's rounded, okay? When you're standing, your spine is relatively in extension, so it's bent backwards to some small degree. And so there you're already building a story for me that says this patient is probably going to respond to extension, but we're going to problem solve and see. Okay? And there are other directions of movement, lateral and some combined movements as well that could be used. So these are some examples of the directional preference movements that we might use. So in the lumbar region, we're working on a motion called a press-up, which is producing that position that the patient was lying on the table where their chest was propped up inadvertently. And McKenzie saw a reduction in the leg symptoms. And this is the same exercise in standing, only because lying down isn't always incredibly useful. People have work and jobs and things to do where they can't lie down, so we have to give them another option. In the neck, one of the main things we find is people present with what we call a forward head posture. So the head is jutted forward, and as we all become more computer oriented, we're actually seeing more of that because we sit in this position all day typing on our computers. So the motion we work on is called retraction. So it's pulling the head back, trying to align the ear with the tip of the shoulder, and that's working on some extension in part of the spine as well. This is an example of a lateral movement. So sometimes there has to be a sideways component to what happens. So we're shifting the hips to the side, working on unloading the structure that may be damaged. So from A to Z, the way it would work is you would come in and we would do the evaluation to determine the directional preference of reducing your symptoms. We would talk to you about those findings, and then we would instruct you into how to stay out of the position that creates your pain and repeat movements into the direction that decrease your pain. We'll continue with those directional preference movements until the centralization is consistent. I don't want someone to come in and say, my symptoms have been centralized for a few hours now. I'm looking for someone to say, I really haven't had any of my leg or arm symptoms for a few days. And when we get into that point, we're ready to move into the strengthening and the functional activities to start getting you back to your normal life, your normal things that you want to be doing. And then we introduce movement into the once avoided direction. So to use a really simple example, a very common finding for low back patients is they come in, they have more pain when they're sitting or bending, they have less pain when they're standing or walking. So we may find that press-up motion is their movement that centralizes their symptoms. And interestingly, most patients who have back pain are a little bit nervous about doing that direction of movement when I first ask them to, because they think that's crazy, that's really going to hurt my back. They're often pleasantly surprised to find how quickly it reduces their leg symptoms and how simple it is to make themselves feel better. So once we determine that movement, we're going to educate them on active involvement. They need to take responsibility and ownership for decreasing these symptoms, because the more we can keep the stress off of the damaged structure, the sooner we can allow it to heal, and the sooner we can allow the patient to feel better. So the goals are to decrease the pain quickly, restore the function and independence, and do it in a minimum number of visits. Hands-on techniques are applied if the patient can't manage the symptom reduction on their own. So if a patient is working on that press-up motion and they're thinking, it feels pretty good, my symptoms are quite a bit better, but it's still down here in my buttock, it's not all the way into my spine, the therapist can add some extra techniques to help improve how much mobility is happening at those segments in the back and further reduce or centralize the symptoms. Learning how to self-treat their problem lets a patient gain hands-on knowledge as to how to minimize any recurrence. That's one of the things I like best about the McKenzie approach is there's so much patient education. The patient leaves here feeling pretty confident that should they ever have another episode of this in the future, they're going to know what to do to minimize it as rapidly as possible. There have been lots of attempts by different researchers and therapists to identify a consistently effective intervention for back pain, and they've been largely unsuccessful. Some patients get better with rest, some patients get better with this or that, and it's been difficult to find something that works for patients across the board who present with a certain set of symptoms. There's a process that happens called the development of clinical prediction rules. These are tools that are designed to assist clinicians in decision making when they're caring for their patients. So we might have a set of a certain group of symptoms or things to look for that a patient might present with, and if they present with a certain number of those things, the clinical prediction rules would guide us toward a certain type of treatment. Spinal manipulation has been identified as one of the more successful spinal treatment techniques. And because of that, a clinical prediction rule has been established regarding that manipulation. In a study conducted by the University of Washington, it was shown that 1 month after completing treatment, patients receiving the McKenzie method improved to the same degree as patients receiving manipulation. But most importantly, the patients treated by the McKenzie method required fewer treatments to achieve the same amount of improvement. And it's also, notedly important that it's a treatment the patient can do to themselves. When you're not in the clinic, how can you help yourself if you can't perform a manipulation on yourself? So this is another possible tool for you to use to self-manage once you learn about it. There was another case study in 2010. A patient met 4 out of 5 of the clinical prediction rules for manipulation. He failed to respond to 2 sessions of manipulation, but then did respond to the repeated movements of the McKenzie approach. So there has not been a clinical prediction rule developed for the McKenzie approach, but what they're starting to do is do some problem solving to see, okay, we have these prediction rules that say manipulation will work. If that fails, does this work? Trying to find ways to guide the physical therapy community in delivering the best care for the patient. The references are here. If anyone needs them, I will be happy to email them to you. And that's my information on McKenzie. If anyone has any questions, I would be happy to answer them. Yeah?
When you say manipulation, what do you mean? Chiropractic?
Chiropractors certainly do manipulation. They call their manipulations adjustments. Physical therapists do a type of manipulation as well. It's mobilization. We grade it through a different grading scale. And so a grade 1 mobilization would be something very gentle, and a grade 5 mobilization would include a thrust movement, which would be similar in idea to what a chiropractor does. Anyone else? Yes?
If the source of the pain is a partially crossed vertebra in the lumbar region,
Is what across the vertebra?
it's a partially crossed
Yep.
vertebra. Half of it's this, half is normal and the other half is
Right.
unnormal. Does this system work with something of that nature, or is there anything can be done.
Right. Well, obviously we can't change the fact that the vertebra is crushed, but what we can do is set up that region of the spine for the best possible biomechanics. So let's say vertebra number 3 is crushed in the lumbar spine.
One.
Okay, vertebra number 1 is crushed, all right? So your body may have, because of that, developed a certain movement pattern that makes you move some segments or vertebra more or less than others to help you avoid pain. So you might have excess motion above or below that, and then decreased motion in the segments right near it, or whatever combination it may be. And the McKenzie technique can help to kind of equalize the amount of motion that takes place across the vertebra to decrease the stress or the load to that segment of your spine. So yes, it can help with decreasing symptoms for that.
Thank you.
Mm-hmm. Yes.
Your presentation of the McKenzie method seems very logical and well thought out. If you were given the book describing it and given all the instructions, do you feel that's enough? And someone were to read it, give you enough.
The treat your own back book or treat your own neck book.
How'd you?
I just read it. You know, it's interesting. I looked at that as part of my preparation to see like what would a patient be reading and how can I incorporate that into what I'm presenting. I think it would give people a general sense of what to do, but not to the degree of actually being able to solve their problem without a little bit more instruction.
Okay, what if you were given this by a physical therapist?
Who gave you instruction or just handed you the book?
Handed you the book.
Then again, I don't think it would be as useful as a full evaluation and treatment session of McKenzie would be. I think you could apply the principles to some degree, but I don't think you would see as quick of a response and as broad of a response as you could with a few sessions of kind of guided or directed treatment.
Can I make a comment on that? Having just tried to help my husband with a disc problem for months and months, and telling him things over and over again, and then I finally bought him the book.
Right.
It has helped a lot to reinforce what I told him all along. But sometimes it helps. Right.
I do find it a helpful tool for patients to look at and read after I've educated them, because lots of times you get so much information in an appointment, you leave with your head swimming and you think, I don't even remember what she said at the beginning of the appointment. And the book does a very good job of kind of taking people through the concept step by step.
Yes, ma'am. Thank you.
Mm-hmm. Yes.
So what if your pain is intermittent? You have to get in here for the evaluation while you're in pain?
It's helpful, but not necessary, because a large portion of determining which category of this you fall in has a lot to do with your history. What movements produce the pain? When do you have the pain? In what postures and positions? And then once we also do some of the screening to determine any range of motion issues, that can also kind of point us in the direction, even if you're not currently having the pain. I will certainly do this problem solving with people who don't have the pain at the moment. They're sitting there telling me I had the pain yesterday, but I don't have it right now. And all I can do during that session is give them, I hate to use the word guess, but my best educated guess about what movement is going to be their problem solver. And I tell them, when you go home, the next time you have the symptoms, I need you to do this, and then you need to come back and tell me what the response was. Because I can't problem solve you right there in the moment because you don't have the symptoms, but I can give you some tools to be able to problem solve it and come back and give me more information so I can take you to the next step. Anyone else? Yep.
Getting back to the idea of being told more information than you can actually retain.
Yes.
Are there now, given the internet, given YouTube, given the ability to actually see the movements properly, do you have that resource so that you would say you should do this, this, and this, and they're either in this book that I give you, or you can go to this website either produced by you or somebody and allow you to see that motion again to remind yourself how to do it properly?
Right. I always hand out handouts when the patient is here, so they leave with papers that describe everything to do. That includes photos and repetitions and all that information. We also do have the books here, the McKenzie books. I let people borrow my personal version if they don't want to buy one, and we sell them also, so there's a couple options there. Certainly, when I was preparing, I was looking at things on the internet, and there are pictures and videos and things, but that's a good suggestion because we could certainly put some of that on our website.
Just reflecting backwards, I had some exercises for shoulder, and there were certain angles, and you had these two-dimensional pictures, and you do it, and then you come back and say, geez, I can't remember exactly what direction I was supposed to be moving these rubber bands.
So we could put some of that up on our website. That's a great suggestion. Yes.
So are there McKenzie exercises to prevent back pain from happening in the future if you don't have it yet?
If you've never had it, or, okay. Probably. It's going to depend on how your spine presents and what your mobility looks like, but most likely when a patient who's anyone over a teenager comes in, we're going to find some anomalies in range of motion and strength and things that are become kind of altered over the course of years. And so if we can remedy those things through some of these movement patterns and make a better balance, then the theory would be that we're going to prevent pain because we're allowing your spine to function in a normal capacity.
And that's what we would do in our posture and flexibility evaluation that we're giving away this evening.
Good. Anyone else? Well, if you think of anything else when you're not here with me, you can always email through our website, and I'll be happy to answer any basic questions you have. But if you have a more significant issue and want evaluation, then that would require an in-person visit. So, thank you.
Thank you, Marsha.